the labs. So let's look at securing the line. There's a lot of different techniques for securing the line, but bottom line is we're always going to put a loop on it here at the bottom. Here, you see they got it looped around their thumb, and we want to secure the IV line so that if somebody goes to move, it just doesn't rip out of them. We want to secure it real good. Make sure you tear your tape before you start the IV, because if you're trying to tear it after you start the IV, it's hard. Because once you start that IV and you get it in, you do not take your hand off of it until it's secure. Trust me, because if you do, next thing you know, it will come out. And they come out very easily. And if you've got a critical patient that's sick, that's the last thing you want to do. Because that might have been the last line you got before you go to an IO. Avoid circumferentially taping around any extremity, because it can start acting like a tourniquet before you know it. And we'll look at the video later. So whenever you go to discontinue your IV, when you go to take it out, make sure you turn the IV fluids off. It does get bad when you take it out and the fluid's squirting everywhere, because the fluid that's coming everywhere, stuff's going everywhere, could be contaminated with pathogens, right? Or the patient's blood. So now you could have an exposure if it gets in your eyes or somewhere. You want to just gently peel back the IV site and stabilize the catheter while loosening the remaining tape, and then we'll pull it out gently. So see, we've still got the tubing applied too. Don't undo the tubing from it. And just pull it out while you're holding pressure here. Then once you take it out, put pressure down and tape it down. Alright, so let's talk about some alternate sites right quick. And some alternate equipment. This is the saline lock we were talking about. We can call them INTs. You may have them called pigtails and stuff. If you use these, make sure you fill them with fluid and flush them, okay? We'll use this mainly for the patients who don't need a lot of IV fluids, like those CHF patients or whatever. But remember, I like using these, and then I'll tie my IV to this. So if I ever got to undo it, I just undo it there. The interosseous, I'll be honest with you, I've never seen one of these. Now this right here, we see all the time. They're called jam chitties. And this is the Easy IO, which all of you should have taken the training class on that, right? The online training class. Or if not, you will. There's a link on there on how to do it. The Easy IO, we use that for adults. They're very good and very fast. Very easy. They're easier than starting an IV. External jugular veins. You want to see that EJ done? You've probably seen me do it. So EJs are usually really big. I usually like to use at least an 18 gauge on an EJ. So if I go to start an EJ, and see how we have his head turned to the side. You start and you want to stick downward towards the body. I've seen somebody once go to start one and point towards the head. No, it goes downward towards the body. Not good. And you use it just the same manner as you would an IV. Once you get it started, you will secure it like you would an IV. Now, you're not going to use a tourniquet. Okay? No tourniquet. Now, one thing you can do is if your patient can tolerate it, you can, to help you get this JVD to help pop up so you can get it, you can lift the legs up some, put their head a little lower. That'll help sometimes. That'll help you with that. But once you start it, just notice when you're starting, your flash may not be as fast as it is with a regular IV because you're not using a tourniquet. So whenever you'll feel a pop, just wait a second and see if you get any flash or return, okay? So
You talking
trouble.
about before you thread it on in?
Yeah.
Okay.
So before you throw it in, like whenever you're going to start it, you'll feel that traditional pop. Because when you start an IV, whenever you go in the vein, a lot of times, sometimes you may not feel it, but a lot of times you're going to feel it feels like a little pop. And you'll feel it in your hand. Well, you'll feel that with the EJ, but like if it's a traditional IV like in the arm, when you feel that pop, usually immediately you get a flash. Because you've got a tourniquet on there, it's building up pressure and stuff. Well, with the EJs, you don't have that luxury. Put a tourniquet on. If you do, it looks really bad. May not be good for the patient. So when you feel that pop, just wait a second and give it time. Because you're talking about a lot lower pressure than what you're normally used to. Alright, so some factors can influence the flow rate in an IV flowing. If you have some problems, it's not flowing good, check your fluid. Make sure that the drip chamber is filled and it's screwed in properly. Check your administration set, make sure it's not kinked, because the administration set lines can get kinked, they can get under the patient, under their board, and whatever. Make sure, and a lot of the administration sets have little blue tabs on them that will kink the line. You want to take that off. The height of the IV bag, you may have to hang it higher. The type of catheter used, and make sure your constricting band is off. So, possible complications. You can have local reactions or systemic reactions. If you have a reaction, make sure you just discontinue the IV and start somewhere else. So if you have like what we call infiltration, or if you start seeing swelling or something like that, discontinue the site, because it's apparently no good anymore. Thing is, with elderly patients, sometimes you'll start an IV on them and their skin is so loose and stuff, you start that IV and the fluid will just infuse into their skin and into their interstitial spaces, and it may take a little longer for the infiltration to pop up. And sometimes if you start an INT initially and you just push 10 cc's of fluid, it may not show anything. And then when you hook a bag to it, start running, and then you start seeing it swell up. And that's when you want to discontinue it. So this is the infiltration, where you'll just see it get bigger. Phlebitis, you may not see this in the field. And I had an IV started in my wrist when I was in the hospital many years ago, and then I got an infection from it. And it went all the way up to my shoulder, the infection did, my left arm, and I missed almost 3 weeks of work because of it, which was not fun at all. An occlusion, this is a physical blockage of the vein or catheter. And if you have those, just go ahead and discontinue and start you another line somewhere. See, this is like I was kind of telling you about. So the IV started here, but look, all in here. Doesn't look good, does it? Looks like that hurt. That's from a lot of fluid there. Be careful. One thing I want to tell you about the hands that you got to be careful from is sometimes if you're feeling, you may think that tendon or ligament is a vein. And in reality, what you're doing is you're sticking to a tendon or ligament, which could cause damage. So be careful from that, okay? That's a big old hematoma there. Are y'all ready for a quick break? Or y'all going to sleep on me?
I had to work a lot.
Yeah. We'll just keep going till 12. Alright, so let's look at systemic complications here. And they can evolve from reactions or complications associated with your IV insertion and can be life-threatening. One thing you do, like have you ever seen somebody that's been in there digging around trying to start an IV, you want to be careful with that, especially if you pull the catheter back, the needle out of the catheter, and you try to push it back in, you could actually cause a needle shear. So some systemic complications can include allergic reactions, air embolus, catheter shear, circulatory overload, and vasovagal reactions. So we want to make sure if we have started an IV and it is working, we don't want to take it out if it's working. But we may have these things we have to deal with. And if we do, then we may need to give more advanced care to us, okay? So let's talk about pediatric IV therapy considerations.
So if I start having an allergic reaction to the site, you're going to discontinue?
No, because the reaction's already there. And more likely, the reason why they're having the allergic reaction isn't because of the IV. It's because of the betadine or something that you use.
Okay.
So we need to get them, and as an EMT, you'll be able to administer epinephrine or something for it. But then, if you take the IV out, what's the chances of you getting another one?
Right.
We want to leave that in.
Or the allergic reaction happening again, you do.
Yeah, may have another one.
Betadine or whatever.
Yeah, then, well, if you can figure that out, don't use betadine anymore. And one thing you can ask the patients too is if they're allergic to shellfish or something,
Use betadine too.
don't use betadine. Because the betadine, I believe, comes from some shrimp shells or something. Something to do with it? I'm not sure, but we can look it up one day. So pediatric IV therapy considerations, if you can see, you know, we've got a whole list of needles over here. More than likely on the pediatric spectrum, you're going to be like over in this area, right? Maybe a 20 gauge. Butterflies are good. Scalp veins are best used in infants and stuff. Now, if you're going to start an IV on a ped, on a kid, make sure you explain to the parent what you're doing, because the kids are just going to go crazy. They're not going to act too well. They're going to start acting up, kicking, screaming, and everything else. You may need to enlist the parent to help you, to help hold the patient there, because that will actually help the patient be calmer if they see mom and dad helping. Sometimes not. Sometimes you just need extra help, because I don't know where kids get this super strength from, because they're strong.
It's their epinephrine
Yeah.
and adrenaline.
One thing, after you start a pediatric IV, protecting the site is vitally important. So after you start a pediatric IV, you may need to start get like an arm board or splint or something and splint it in place. And keep your eye on them so they don't pull it out. Because you'll have two types of kids. One type is, once you start the IV, they don't want you messing with it because they perceive that IV as now being an extension of their own body. And that's theirs. The other type is they want it out. And they'll pull it out. So you want to keep an eye on them and stuff, and because they're hard enough to get to begin with. The geriatric IV, it's almost the same way. You have to use smaller catheters sometimes. Now, one thing I'm going to tell you from experience is that if you put a tourniquet on a geriatric patient, sometimes you'll have these nice veins that pop up, and then you say, oh man, I can get a 20 gauge and that easy. And you take that 20 gauge, you go to hit it, and it blows like a freaking balloon right whenever you hit it. You see it right on the skin. Pop, you get flashes, pow! Well, dang, what happened? Then you do it again. Pow! Well, sometimes what you need to do is either use a smaller catheter or don't use a tourniquet. Sometimes the high pressure, their veins are just so weak, that pressure just pops like a balloon. So I've done it where I just didn't use a tourniquet. Now remember what I told you about the EJ. If you're not using a tourniquet, you may have a slower flash, right? So you may just have to be a little slower and more gentle.
Just use eyes.
Yeah. Now I'm going to tell you, let me just you know, we'll talk about IOs a little bit, but whenever you start the IO and you infuse fluids and stuff to that IO, even if it's a conscious patient, it hurts. I've done it, I've started an IO.
Starter the whole time.
When the fluid's being infused, they feel the fluid going through. And especially for y'all, because you're not able to give any pain medication through it. We give, as the paramedics give lidocaine through it to help try to numb it, but it still hurts them.